Hello, InstaFam. It is Dr. T here on a chilly Wednesday night in Perth. I actually have already reverted to the cup of tea. This is a gorgeous cup that was actually gifted to my daughter, S for Sophie, and my other daughter, D for Daisy, got one too. Actually gifted by my beautiful aunt Sue, Auntie Sue, who lives in the UK. And she lost her battle with cholangiocarcinoma a couple of weeks ago. It was a really, really rapid decline, and I barely got to say goodbye. So I am drinking a beautiful cup of steaming tea out of the cup that she gave my daughter, and just thinking about her. How are you guys? Hey, who joined me last night on Charlie Health? Who came along and listened to our little webinar between Dr. Claudia and me, doing a bit of a Q&A on polycystic ovarian syndrome? Did anyone come along? Let me know what your thoughts are. I am super keen to get your feedback on what you thought about our little webinar, because we are going to be doing some more. And you're probably also a little bit curious about Charlie. So I want to give you a little bit of curiosity tour of Charlie. And I'd recommend that you go and check out the app. So it's CHARLI, Charlie. It is, well, in its simplest form, it's a menstrual cycle tracking app, but it's so much more than that. There are lots of, oh, you missed it. Simply the Becks. Yes, you can absolutely go and rewatch it. I have linked up as a collaborator, so you'll actually find the webinar right on my Instagram page. Or you can go to charlie.health to their Instagram handle, and you will also find the webinar there. But yeah, we hope you really enjoy it. There were some awesome questions asked. Thank you so much to those of you who contributed. But anyway, I was talking about Charlie. So I'm going to tell you guys a little bit about the journey. So I was offered the opportunity to link arms with Charlie a few months ago. And I thought, just another menstrual cycle tracking app. There's heaps of them out there. But what I came to learn really quickly was that what it really is a women's health platform. So it's an opportunity to go into the app, obviously enter your profile and your details, but utilizing evidence-based surveys, questionnaires, performers that have been developed in the arena of women's health around things like pelvic pain, perimenopause, PCOS. You can not only track your cycles, but you can you can use the AI component of the app to start to create a profile for you and give you feedback as to where you sit with regards to normal, abnormal, and so on. You can also start to create a profile for yourself around your women's health that you can then share with a medical practitioner. You can access educational material that has been produced by FRANS, COGS, so people who have training in obstetrics and gynecology, CREI, certified reproductive endocrinology and infertility specialists, women's health GPs, dare I go on. And this is just the beginning. What is coming out over the next several months, the material that is being produced by these doctors and allied healthcare professionals is insane. And it really taps into my, preventative holistic health messaging. It is your women's health platform in your pocket. So that's really, really, really exciting. And I can't wait to see how Charlie grows, particularly into the areas of fertility management, pediatric adolescent gynecology, menopause management, post-menopause management, They started out creating stuff around pelvic pain and endometriosis. So if you want to just go and check out that stuff now, you can. But it's super exciting. And they're just an awesome bunch of doctors and allied healthcare professionals to work with. You know how when you get together with a group of people and they just raise you up and inspire you, like that brains trust. So yeah, really exciting stuff. So I will be continuing to link arms and collaborate. The next webinar that is in the calendar is the 23rd of the 7th, the 23rd of July. We will be talking about hormone dominance. It's something I hear all of the time. We're going to bust some myths around hormone dominance. We're going to explain exactly what it is. Is it really a thing? Is it something that's pathological? Is it going to affect our reproductive health, our mental health, our fertility health? Like, let's talk about all things hormone dominance. So just keep an eye out for that. You can also tap into a bit of Charlie chat with a few of the other healthcare professionals who will be getting on periodically. Dr. Matt and Nurse Sam will be getting on Friday night to have a bit of a Charlie chat about the app, how you can best use the app, and also some other questions that they commonly get from their community. So now you're all on here. There's a few people. Hey, Life of Brit, you joined me last night. Thank you for being on. Alyssa Mills, Tamarin, Daniela Stocco, I think you were on last night. Thanks for hopping on. Libstar, you were on last night. So guys, here is your opportunity, Q&A. We're going to stay together for around about 10 minutes. What I want you to do is drop into the chat any questions that you have around women's health. Obviously, I get a lot of fertility stuff, but anything will do. Try and make it succinct. Don't need your whole life story. We'll be giving a very generic answer. Obviously, as you guys know, I say it a million times, I'm not on here to do medical consults on social media. That's not how we roll. So I'll make the answers as generic as possible. And I would always recommend that you go and have a chat with your healthcare professional about your individual scenario. So, any questions? Simply the Bex. Any questions? Alexi, Maddie Post, anything, Bueller. You guys aren't typing. Oh, here we go. Hospital Barbie. That's such a cool handle. Do you think there's value in PGT-A as older potential parents? Do I see that there is value? Yes, I do see that there is value. The role of PGT-A, so pre-implantation genetic testing of embryos for the purpose of determining aneuploidy. So aneuploidy, A, means an abnormal number of chromosomes. So the example that I often give people is trisomy 21, means there's 3 copies of the chromosome number 21. That is commonly known as Down syndrome, and many of you know the syndrome associated. So you can have too many of a chromosome, you can have not enough of a chromosome, you can have partial or segmental aneuploidy, like too much or not enough of part of a chromosome. And all of these things can have nasty outcomes. Mostly they will just be embryos that don't implant, or they might miscarry. Worst case scenario, they can end up in live birth of a child with some pretty significant health conditions. So, is there value in PGT-A? Yes. Well, as you know, as a woman ages, the aneuploidy rate of her eggs goes up. So by the time a woman is about 40, by the time she's 35, about 50% of her eggs are chromosomally abnormal. By the time she's over 40, up to 8 out of 10 of her eggs are chromosomally normal. 8 out of 10 of her eggs are chromosomally abnormal. Yeah. So if you are an older woman who produces a lot of eggs, so you've got quite a high ovarian reserve, a high egg number, then quite a number of your embryos that get through to sort of day 5, even though they might look normal under the microscope, are quite possibly chromosomally abnormal. So if you're producing a lot of embryos, that's my dog, if you're producing a lot of embryos, then you could potentially be transferring those embryos. And we all know that a transfer takes about a month of management and planning and intervention and all that burden for you. you might be transferring an embryo that is not going to eventuate into anything. And then you're going to be asking the question, well, why? Well, we can potentially reduce the number of embryos that are transferred over time by testing euploidy status or aneuploidy status. That will save you on transfers. And what that does is reduce your time to an ongoing pregnancy. And I think that that's important when you're older, is time is of the essence. Where I probably wouldn't suggest doing aneuploidy testing or PGT-A is if you're only producing maybe 1 or 2 embryos. I think that the value is significantly reduced because you're just going to transfer that embryo. What is the worst thing that could happen? Well, you could get along to your NIPT or your sort of screening check at around just after 10 weeks of pregnancy, and you could find out that actually that embryo that has implanted and has a heartbeat is chromosomally abnormal, i.e. it could have Down syndrome. And then you have to make that really difficult decision as to what you're going to do. Are you going to continue that pregnancy or not? So that's possibly the worst thing that could happen. And if that just like sends shivers up your spine, then maybe doing aneuploidy testing is going to be of value to you. So lots to think about there. I know I do go on a little bit, but hopefully that has provided some food for thought when considering PGT-A. Definitely chat to your fertility specialist about it. Santinus treasures, does having no lactobacillus in the uterus impact implantation? How do you increase lactobacillus levels? Such a great question. So, the microbiome of the uterus, of the reproductive tract, is kind of, in my mind, the last frontier. We kind of understand that the microbiome changes throughout the month. We know it changes throughout the menstrual cycle. We know that the microbiome in the uterus, the cervix, and the vagina are all really different. And we know that the gut microbiome possibly transfers somehow, we don't really understand, some of the good bacteria to the reproductive tract. But more, what you put in your gut and to improve your gut microbiome probably just changes your inflammation in your body, and therefore that impacts on the endometrial receptivity. We don't know the perfect profile of the microbiome at the time that an embryo is implanting. There has been evidence to suggest that pathological bacteria or a really poor imbalance or perhaps no lactobacilli at the time of an embryo wanting to implant or the window of implantation may be less associated with ongoing pregnancy, more associated with miscarriage. However, equally, there is data that shows that, yes, this person didn't have any lactobacillus, but they still fell pregnant. So it's a very new area of research. Lactobacillus crispatus is thought to be the most important lactobacillus at the time of implantation. But again, this is just emerging data. But the fact that you don't have any lactobacillus in the uterus, I guess it really begs the question, what time in your cycle? Was there any other pathological bugs there? Are you symptomatic of that? What is your reproductive history? Like, all of those questions are really important. How do you increase the lactobacillus levels? I think with great difficulty. I have involved naturopathic care in this because I do believe that naturopaths probably understand this arena better than we do. But it's really important that you find a naturopath that is good at this stuff, because not everybody is. Even a dietitian, as I said, we're not really sure how, but we think that the gut microbiome might play some sort of a role in either changing the inflammation or possibly even changing the microbiome in the reproductive tract as well. So watch this space. I think it is a very interesting space in the research. I don't think we have come up with the ideal treatment or even ideal diagnostics around the microbiome, but it does it does seem that lactobacillus is possibly the most important bacteria that we have there at that time. Good question, I love it. Hayri, how quickly does stage 3 endo grow back? Oh, that's a really loaded question. I guess it depends on how well it was resected, how extensive it was, did you have deep and infiltrating lesions, or just was it really widespread? Often deep and infiltrating lesions might not have been well resected unless you're perhaps dealing with an AGES qualified surgeon. So it depends on the skill level of your surgeon. And I think we're still figuring out that there are different kinds of endo. Like we see people with endometriosis that just involves their ovaries. We see women with endometriosis that is sort of right throughout their peritoneal surface, but really superficial. And then we see those with deep and infiltrating disease. But certainly what I can say from, I guess, a reproductive perspective is the data shows us that if you can resect minimal to moderate disease, you can allow somebody's spontaneous pregnancy rate to be increased, but only over the next 6 months. So the data says pregnancy rates only increase in the 6 months following surgical resection. So that probably speaks to how quickly disease can therefore return. Whether that relates to stage 3 endo or not, I'm unsure. But certainly if I have resected endo, I will typically say to a patient, if you have not conceived in the next 6 months, come back and see me. I tend not to be operating on stage 3 endo because the data actually says that medical suppression of advanced endo is actually going to improve pregnancy rates. So I tend to treat it medically. But again, this is something that's important for you to go and speak to your fertility specialist about. Simply the Bex. Do you think that taking the pill to block a period for 3 months is risky business? No. I think it's really wise. I think that if you've got stuff going on, if you find that your periods are really painful, if they are really interrupting your quality of life, there is absolutely no harm in taking the active pill in a continuous fashion. In fact, not long ago, there was a pill on the market that I don't actually think it's still available, but that was 3 months. Like you would take the active pill for 3 months and then have a bleed once every 3 months. That's 4 periods a year. That's fantastic. So it is not at all risky business. I think it's quite smart, really. Lancaster Emma, should you do an egg retrieval before going on Ozempic? Ozempic is not thought to have any deleterious effect on eggs. And we do recommend that if you are trying to conceive, including with IVF, that you probably have a good month washout before you start trying to conceive. And that's only because the research on Ozempic and teratogenicity just in humans just hasn't been done. So we don't know yet if it is teratogenic, but no one really wants to risk it. So I would always say to my patients before starting fertility treatment with the intention of falling pregnant to cease it, I don't feel strongly about the need for you to cease it if you are, say, freezing eggs, for example. So play on. I think it's a great drug. Hospital Barbie, you're very welcome. Oh, Louise, how are you? Astrid's on, Sonal is on, the Midnight Gang, My Pleasure, Santina's Treasures, Hayri, welcome, welcome, Simply the Bex, thank you. Do you know what? As usual, I've gone over time, well over time. Are there any more last minute questions? Otherwise, we will sign off. And I want to let you guys know, oh, I'm glad I remembered. I have 9 vouchers. I was trying to think of the word then. I have 9 vouchers for you guys over the coming weeks to allow you 6 months free access to Charlie app. I spoke about it at the beginning. It's an amazing new women's health platform that utilizes AI to help support you in your menstrual and reproductive and endocrine and female health. It's all evidence-based, developed by medical practitioners. I'm super excited to be linking arms with them. And I have a series of vouchers that I want to be able to give away. So keep an eye out on my socials over the next couple of weeks and make sure that you go in the running, because 6 months free of this app could just make a whole heap of difference to your life or somebody else's life. So keep an eye out. Keep an eye out for our next webinar that we'll be doing on the 23rd of the 7th, talking about all things hormonal dominance, because everybody asks me, oh, Life Bex, I popped a question in the question box. Oh no, did you? I can't see it. Did you send me a DM maybe? Oh, you put in the question box on socials. Do you know what? I'm going to answer that separately because I've got to look. Soz. Maddie Post, how frequent? Oh no, because you've yeah, well done, girlfriend. You've posted here. Maddie Post, how frequent is pelvic pain with no obvious cause? And is there any research at the moment about what the causes could be? Pelvic pain, Maddie, is a very, very complex thing. And certainly a process of elimination is really important, including obviously ruling out endometriosis. But there is a lot of research in the pain field looking at nociplastic pain, neuropathic pain. I find it a very intriguing area. I think it requires multidisciplinary management, everything from physio to psychology to mindfulness and even pharmacotherapy. So there is always lots of research going on in this space, and I would certainly involve, particularly if you've ruled out anything organic, I would certainly be involving the care of a very clever pain specialist, because it really is multidisciplinary care, that one. Like Beckons, can you please speak to your experience of taking women off the endocrine therapy for breast cancer so they can pause treatment and carry their kids? Oh, hey, what's my experience? Well, I can touch base briefly on, the positive trial, which looked at women who were hormone receptor positive, so estrogen receptor positive, who were on anti-estrogen therapy, and they were taken off after 18 months. So that's really important. They were taken off their therapy only after they completed 18 months of treatment. I'm just at month 4, 5, and let me tell you, it is hardcore. Anyway, the expectation really is to be on hormone blocking therapy for 5 to 10 years. So that doesn't bode well for women who want to carry a baby. So the evidence suggests that if women are taken off their hormone blockers for a period of time, 12-ish months, to allow them to conceive, there is not thought to be any significant increased risk of recurrence or effect on prognosis. Generally speaking, because it takes a bit to get pregnant, most women are encouraged to seek assistance to make that a bit faster, like using assisted reproduction. So the data is encouraging, and I have had a couple of patients come off their hormone blocking agents in order to conceive using embryos that they had frozen prior to going through their breast cancer treatment. So my experience is somewhat limited. I won't say I've treated hundreds of patients, but I have treated a couple, and I'm really buoyed by the evidence that is out there. Sonal Harani, does being on the pill long-term affect chances of conceiving naturally? No. In fact, you mean in a negative way? No. In fact, the pill can help to improve the chances of conceiving in someone who perhaps has a background history of endometriosis, or perhaps someone who has PCOS. So the pill actually can be really, really helpful in those who have pathologies that would otherwise affect their ability to conceive. All right, last one question. Babicuri, spotting during the luteal phase, normal? Absolutely not. So many people say to me all the time, oh, I've got an implantation bleed. I tell you, the implantation bleed is not a thing, right? spotting in the luteal phase is not normal. It can herald things like endometriosis. It can herald luteal phase defect. It can herald other pathologies like a polyp inside the womb. So please go and get checked out by your doctor, but it's definitely not normal. Okay, I'm done. I am done. Life beckons. Please go back and have a chat with your fertility specialist. I don't want to speak out of my realm. You need to go and have a chat to your fertility specialist about testing your embryos. Right, guys, that's it for me tonight. I am done. Well done. Great questions. Thank you so much for sharing. I will see you on the flip side. I will be back next Wednesday, and then hopefully I'll be able to do a little live to you from Amsterdam, where I'm going to attend ESHRE. First time I've done it. So exciting. I'll see you next week. Bye.